The case has a title, and the title is telling you the subject. We are going to talk about arterial graft failure and what the people normally call the benign string sign, that in fact could be a more complex phenomenon. What we know about the failure of the radial artery, the incidence and mechanism of radial artery graft failure are still matter of debate. It is not clear whether the angiographic finding of so-called string sign is related to autoregulation of this highly reactive muscular conduit or to accelerated degeneration. And we don't have any information about the possible additional value of imaging to guide procedure. Here is the man, 58 years old, sport person, no history of CAD. We discovered during his hospitalization an unknown high level of LDL. He went to the hospital with unstable angina, and you may see the three vessels. Good distal possibility, younger person. Let's discuss with the surgeons, and let's try to get a full arterial revascularization. The heart team said, okay, LAMI on the LAD, RAMI on the marginal branch, and radial artery on RCA. And here you have, in a huge series of patients, more than 400, the patency and the rate of failure when you are using ITA, radial, and saphenous vein graft. And of course, it has been proven advantage compared to saphenous vein graft, especially in younger patients, and especially when you are looking at the mid, longer-term follow-up. So 2 ITA and 1 radial. He was discharged quickly without any problems on beta blocker, atorvastatin, and aspirin. 4 months later, the patient was hospitalized with a prolonged chest pain and inferior STEMI. Check always by radial coronary artery, never touch the left. So in this case, you can see the patency of the RAMI and the patency of the LAMI that is not running, but I don't know why. And fortunately, that is a problem because it was testing perfectly below, but now it seems that is not running. Anyway, can you click? So in the test, all was perfectly running. It doesn't matter. The original, the native right coronary artery that previously was a patent was totally occluded. And unfortunately, if you cannot arrive to run this video, that could be a trouble. While in the LAD, we have in the radial arterial graft, we have 2 different locations of reduction of significant reduction of the caliber. The first one was distal and it was more uniform before the graft insertion, and then there was one more proximal, quite severe. And here you can see the acquisition done by OCT. Distal part, proximal part, automatic lumen profile. Here we can go back.
This is on the REMA or the LEMA?
This is the radial artery.
Radial, yeah, okay.
The LEMA and the REMA were perfectly patent and normal. The original right coronary artery was occluded, and there were 2 segments of the angio with very high significant stenosis, one more focal proximal and one more distal uniform. This is the original posterior descending artery. Then we are going to get the bifurcation of the right, and then we are entering the radial graft. Here you can see the distal portion. I'm trying to move back to this zone with an incredible neointimal proliferation. This was the mid-distal part of the radial graft. Then you can see a much more proximal one, where the arrangement of the vessel is completely different, where you can see also a layering inside this part of the vessel with a lot of irregularities and a small dishomogeneity in density. Let's try to sum up the situation. This is the original native artery that you can see here, distal of the right. This is the segment that was more distally of the radial graft with this type of arrangement. And then is the most proximal part where we have a completely different arrangement. Let's go back quickly to how it looks like the radial artery and how it looks like in OCT in this study that was done looking to the conduit quality of the discard segment that were used for grafts. Here you have the comparison of the radial artery and the saphenous vein graft. What is important, a radial artery practically does not have the intima. They have a very distinct EL here. Then you have the media, and then you have the adventitia. In a different way, the saphenous vein graft has a much clearly defined EL, and then you have the media and the adventitia. Here in this graph, you can see much clearly. This technology was used to try to assess the reliability of OCT in assessing graft of all types. Here you have the very high correlation coefficients to assess conduits for fibrous tissue, for calcified tissue, and for lipid-laden. And you can see also the capability of OCT in getting exactly the thickness of the intimal and media. So what we know in terms of preparation is that while the internal thoracic artery is harvested with a no-touch technique, saphenous vein graft and radial artery harvests frequently involve a manual distension to resolve a spasm and followed by hypoxic storage. This factor might disrupt intimal integrity and increase the risk of early failure. And the early failure is normally when you have a less significant stenosis in the graft vessel, but it was not this case. It was subtotally occluded when it was grafted, or also when you graft the right coronary artery. This is what the literature said about the string sign, that normally is only an increased amount of neointimal proliferation. And this is what the literature said. They say, well, this artery is very different compared to the ITA in terms of luminal narrowing and thickening. Here you can see what was done. I'm moving inside. This is a conversion of the original sequence by using ultrasound to show what we call the EL. And here you can see the normal radial artery in the proximal segment. You can see very minimal or not existing intima. Then you can see the media and the adventitia. Then you follow my sequence. And here we are going to the segment that was more tight. And you see how the vessel is changing in terms not only of external elastic lamina, but also in terms of composition of the tissue. And then there was another segment that was with a little bit of neo-intima and then a lot of neo-intima at this point. And finally, if you are going distally, you started to see the normal vessel in the distal right coronary artery. So different segment with a totally different pathology. Here is the calculation of the severity of the lesion at the most severe point. With the same trouble, we decided to place a 3.0 stent without stretching too much, only in the proximal segment where we have not only this significant stenosis, but also the tissue was different, leaving the distal uniform neo-intima without touching. The patient was discharged in calcium blockers and atorvastatin. He remained asymptomatic. He did one exercise test up to 225 watts, negative maybe. The LDL went down, but not at the level we wanted to have. And we got the patient back for an elective control at 8 months of follow-up. And here you can see the sequence. We can stop for a second to have a look inside the stent, if possible. I'm moving inside the stents. Here is the second half of the stents, where you continue to see the struts, but you have a very layering tissue in the external part, and then the distal portion with neo-intima that we left stay unchanged with a lot of neo-intima tissue. At this point, this is a magnification of what we saw. So we decided to switch the patients to the PCSK9 inhibitors. The LDL declined at 30 milligrams per DL, and we are watching the patient that is 1 year later doing well and doing a normal life. So my case-based conclusion, OCT is an accurate and a reproducible, clinically relevant method to evaluate the radial artery conduits for pathology that would be otherwise misinterpreted by means of CAG. OCT has enough resolution to detect different abnormality and to measure IMT. The traumatic or pre-existing pathology in radial artery conduits is much more common compared to the ITA. OCT may assess radial conduit integrity both at the harvesting and in vivo. String side are not only benign, they might have a different etiology. Similar angiographic findings in the graft segments were associated with different underlying conditions: intima hyperplasia, spasm, that was not this case, or atherosclerosis. The more effective intervention in radial artery failure remain to be demonstrated. Thank you very much.